I'm Dr. William Carter, a board-certified urologist and pelvic surgeon practicing in the United States for over 25 years, and in that time I've cared for thousands of men who've faced the diagnosis of prostate cancer and undergone radical prostatectomy. I know what keeps you up at night. You've been told you need your prostate removed, and the first thing that floods your mind is fear that you'll never be dry again, that you'll leak urine every time you stand up, that your sex life is over, that somehow you'll be less of a man. I want to tell you right now, with absolute clarity, that those fears are not the default outcome. Yes, there is a recovery process. Yes, there are challenges, but the overwhelming majority of men who have this surgery go on to live full, active, confident lives. They return to work, they travel, they exercise, they have intimate relationships, and they stay cancer-free. That is the truth, and that's what I'm here to walk you through today step by step, without sugarcoating, but also without catastrophizing. You deserve to know what really happens after prostate removal. Not the horror stories whispered in waiting rooms, but the actual medical reality, paired with the practical guidance that helps you navigate this chapter with confidence and hope. Before we go further, if you or someone you love is facing prostate surgery, subscribe now. I answer questions in the comments and post weekly guidance on continence, sexual recovery, and long-term health. Tell me below what worries you most: leakage, erections, or the surgery day itself. And if you know a friend, a brother, a father who's just been diagnosed and is terrified, share this video. Knowledge is power, and community matters. Now let me take you through this journey the way I would if you were sitting across from me in my clinic. First, let's talk about why we're even here. Prostate cancer is the most common non-skin cancer diagnosed in American men. 1 in 8 men will be diagnosed in their lifetime. That sounds terrifying until you understand that the vast majority of prostate cancers we find today are localized, meaning the cancer is confined to the prostate gland itself, and that makes it curable. We find these cancers through screening, usually a blood test called SAW, or prostate-specific antigen, sometimes paired with a digital rectal exam. If your SAW is elevated or the exam feels abnormal, we often proceed to MRI of the prostate, and then a biopsy, where tiny tissue samples are examined under a microscope. If cancer is confirmed, we stage it. That means we figure out how aggressive it looks under the microscope, what the Gleason score is, and whether it's still contained within the gland or has spread beyond. For localized prostate cancer, especially in men who are healthy enough to live another 10 to 15 years, radical prostatectomy, complete surgical removal of the prostate gland, is one of the most effective treatments we have. The cure rates are excellent. We're talking about the potential to eliminate the cancer entirely, to render you cancer-free for the rest of your life. That's a powerful statement, and it's the reason men choose surgery. But of course, removing an organ that sits right below your bladder, wrapped around the top of your urethra, nestled next to the nerves that control erections, that's delicate work, and recovery requires patience, intention, and partnership between you and your care team. Let me explain what the prostate actually does, because understanding the anatomy helps everything else make sense. The prostate is a walnut-sized gland that sits directly beneath the bladder. The urethra, which is the tube that carries urine from your bladder out through your penis, runs right through the middle of the prostate. The prostate's job is to produce a component of seminal fluid, a liquid that mixes with sperm during ejaculation. That's it. It's a reproductive organ. It does not control your ability to have an erection, and it is not essential for survival. You can live a completely normal life without a prostate. What makes surgery possible and curative is that when cancer is confined to the gland, we can remove the entire gland, along with the seminal vesicles attached to it, and reconnect the bladder directly to the urethra. That reconnection, which we call an anastomosis, is the critical step. It's where your urinary stream will flow after surgery. And it's the site that needs to heal over the first few weeks. The nerves that control erections, by the way, run along the outside of the prostate, very close to it, in bundles on either side. During surgery, if it's safe from a cancer standpoint, we try to preserve those nerves. That's called nerve-sparing technique. Whether we can spare one nerve, both nerves, or neither depends entirely on how close the cancer is to the edge of the gland. Oncologic cure always comes first. If sparing a nerve means leaving cancer behind, we don't spare it, but when we can, we do, because it dramatically improves the chances of preserving erectile function down the road. So what does surgery day actually look like? Let's walk through it. You'll arrive at the hospital or surgical center in the morning, usually after fasting overnight. You'll meet the anesthesia team, and they'll place in give you some relaxing medication, and then take you back to the operating room. You'll be under general anesthesia, which means you're completely asleep and pain-free during the entire procedure. The surgery itself typically lasts 2 to 4 hours, depending on the complexity and the technique used. Open, laparoscopic, or robot-assisted, which we'll talk about in detail shortly. When the operation is finished, you'll wake up in the post-anesthesia care unit, or PACU, where nurses monitor your vital signs, your pain level, and your overall stability. You'll notice a catheter in place, a thin, flexible tube coming out of your penis, draining urine into a bag. I'll explain why that catheter is so important in just a moment. Most men stay in the hospital for 1 to 2 nights after prostatectomy, sometimes just 1 night if everything goes smoothly and you're feeling well. During that time, we encourage you to get up and walk, even just short trips around the hallway, because movement reduces the risk of blood clots, helps your bowels wake up, and improves circulation to promote healing. You'll start with clear liquids and advance to a regular diet as tolerated. Pain is generally manageable with oral medications. Most men describe it as deep soreness or pressure rather than sharp pain. By the time you go home, you'll have prescriptions for pain control, possibly a stool softener, because pain meds can cause constipation, and detailed instructions for catheter care. Let's talk about that catheter, because it's one of the most misunderstood and anxiety-provoking parts of early recovery. The Foley catheter stays in place for about 7 to 14 days after surgery, sometimes a little longer if there are concerns about healing. Its job is to keep urine flowing freely away from the anastomoses, the reconnection site between your bladder and urethra, so that area can heal without being constantly bathed in urine. Think of it like a cast protecting a broken bone. The catheter does the work so the surgical site doesn't have to. It's held in place by a small balloon inflated inside your bladder, and it drains into a leg bag during the day, or a larger night bag while you sleep. Yes, it's uncomfortable. Yes, it's inconvenient. You might feel bladder spasms, sudden, crampy sensations that make you feel like you need to urinate, even though the catheter is draining continuously. Those spasms are normal, and usually respond to medications we can prescribe. You might see some blood-tinged urine in the first few days, especially after you've been active. That's normal too, as long as it's not bright red or full of clots. What you need to watch for are signs of infection, fever over 101 degrees, foul-smelling urine, or severe pain that doesn't improve with medication. Those warrant a call to your surgeon. Otherwise, keep the catheter taped gently to your abdomen or thigh to avoid tension. Keep the drainage bag below the level of your bladder so urine flows downhill. And shower daily to keep everything clean. Most men tell me the catheter is more annoying than painful, and the relief they feel when it finally comes out is immense. Removal is quick and uncomfortable for about 5 seconds, and then it's done after it's out. You're going to urinate on your own for the first time since surgery, and that brings us to one of your biggest concerns: continence. Here's what I need you to understand about urinary control after prostatectomy. Temporary leakage is common. Let me say that again, temporary. When the catheter comes out, many men experience some degree of urinary leakage, ranging from a few drops with coughing or standing to more significant leakage with activity. This happens for several reasons. First, during surgery, we work very close to the external urinary sphincter, which is the circular muscle that clamps shut to hold urine in. That muscle can be temporarily weakened or irritated. Second, the pelvic floor muscles, the hammock of muscles that support your bladder and help coordinate urination, have been through trauma and need reconditioning, just like rehabbing a knee after surgery. Third, the anastomoses itself is swollen and healing, and your bladder is adjusting to its new plumbing. All of this improves with time. The trajectory looks something like this in the first few days to weeks after catheter removal. You'll likely need pads, absorbent pads designed for men, which you can find at any pharmacy. Some men start with heavier protection and transition to lighter pads as control improves. By 6 weeks, many men notice significant improvement. By 3 months, the majority of men are either completely dry or have only occasional minor leaks with heavy exertion. By 6 months, that number climbs even higher. By 12 months, roughly 85 to 95% of men have excellent continence, meaning they either use no pads or maybe one light pad per day for security. Now, that also means that a minority, somewhere between 5 and 15%, depending on age, surgical technique, and other factors, will still have some degree of persistent leakage at the 1-year mark. For those men, we have excellent solutions, and I'll cover those shortly. But the key message is this: early leakage does not predict long-term outcome. Patience and active participation in pelvic floor rehabilitation are your best tools. Pelvic floor physical therapy is something I recommend to virtually every man after prostatectomy. This is not regular physical therapy. This is specialized rehabilitation with therapists trained in male pelvic health. They teach you how to correctly identify and engage the pelvic floor muscles, often called Kegel exercises, though it's much more sophisticated than just squeeze and hold. The goal is to coordinate these muscles with breathing, posture, and movement. Many men inadvertently bear down or tighten the wrong muscles, which can worsen leakage or cause pelvic pain. A skilled pelvic floor therapist can use biofeedback, internal or external techniques, and functional training to help you regain control faster and more effectively. They'll also address any habits that contribute to urgency or leakage, like poor fluid timing, bladder irritants in your diet, or improper voiding techniques. I can't emphasize enough how valuable this is. Men who engage in pelvic floor therapy tend to regain continence sooner and with more confidence. In the meantime, there are practical strategies that help. Use timed voiding. Go to the bathroom every 2 to 3 hours, even if you don't feel a strong urge. To keep your bladder from overfilling and leaking, avoid caffeine, alcohol, and very spicy foods in the first few months, as they can irritate the bladder. Stay hydrated, but don't overdo it. 6 to 8 glasses of water a day is usually sufficient. Manage constipation aggressively, because straining increases abdominal pressure and can worsen leakage, and use pads without shame. They're a tool, not a failure. Now, what about the men who don't regain full continence by 12 months? First, we investigate. Sometimes there's a mechanical issue, a stricture or narrowing at the anastomosis site, which we can often fix with a simple outpatient dilation or minor procedure. Sometimes there's overactive bladder contributing, and medications can help. But if the issue is truly stress, urinary incontinence, leakage with physical activity due to sphincter weakness, we have 2 main surgical options, and both are highly effective. The first is a male urethral sling. This is a mesh ribbon placed beneath the urethra to provide support and compression, like a hammock, lifting and reinforcing the sphincter. It's an outpatient or short-stay procedure. Recovery is relatively quick, and satisfaction rates are quite good, especially for men with mild to moderate leakage. The other option is the artificial urinary sphincter, or AUS, which is considered the gold standard for severe incontinence. The AUS is a device with 3 components: a cuff that wraps around the urethra and keeps it closed, a small balloon reservoir placed in the abdomen that regulates pressure, and a pump placed in the scrotum that you squeeze to open the cuff and allow urination. It sounds complex, but it's remarkably intuitive. Men who receive an AUS typically achieve excellent dryness, often 0 pads per day, and report very high satisfaction. Recovery involves about 6 weeks of allowing the device to heal in place before activation. But once it's working, it's life-changing. I've seen men go from wearing 4 or 5 heavy pads a day to nothing, and the impact on their confidence and quality of life is profound. So even in the minority of cases where continence doesn't fully return naturally, we do not leave you stranded. We have solutions. Let's shift now to the other major concern: erectile function. This is often the subject that men find hardest to talk about, even with their doctors, and I want to normalize that conversation right now. Erections are a complex interplay of psychology, hormones, blood flow, and nerve signals. The nerves that carry the signal from your brain to your penis to initiate an erection, the cavernous nerves, run along the outside of the prostate in very delicate bundles. During prostatectomy, even with nerve-sparing technique, those nerves are stretched, manipulated, and sometimes bruised. Think of it like a minor injury to a computer cable. The cable might still be intact, but the signal doesn't travel as efficiently right away. In some cases, especially if the cancer is very close to the nerves, we have to remove one or both nerve bundles entirely to achieve clear margins and eliminate the cancer. When that happens, spontaneous erections will not return without intervention. But even when both nerves are successfully spared, it takes time for them to heal and for erectile function to recover. We're talking months, sometimes up to 12 to 24 months, for nerves to regain full conductivity. During that time, you may have no erections, weak erections, or erections that come and go unpredictably. This is normal, this is expected, and this is where penile rehabilitation becomes essential. Penile rehabilitation is a proactive approach to preserving erectile tissue health and maximizing the chances of functional recovery. When erections don't occur regularly, the smooth muscle tissue inside the penis, the corpus cavernosum, doesn't get oxygenated the way it normally does. Over time, that can lead to scarring, shrinkage, and permanent damage. Rehabilitation aims to prevent that by encouraging regular blood flow to the penis, even if it doesn't result in a firm enough erection for intercourse initially. The strategies include DEFIV inhibitors, medications like sildenafil, tadalafil, vardenafil, which work by enhancing blood flow when nerve signals are present. Some men take these on demand before sexual activity, others take a low daily dose to promote regular blood flow. Another tool is the vacuum erection device, or VED, which uses negative pressure to draw blood into the penis, creating an erection that can be maintained with a constriction ring at the base. It's mechanical rather than spontaneous, but it works, and it's an excellent option for rehabilitation and for intercourse during the recovery phase. If oral medications and vacuum devices aren't sufficient, we can consider intrawear suppositories, which deliver medication directly into the urethra, or intracavernosus injections, where you inject a medication into the side of the penis to induce an erection. I know that sounds intimidating, but the needle is tiny, the injection is nearly painless, and the results are often very reliable. Many men use injections as a bridge therapy while waiting for nerve recovery, or as a long-term solution if nerve recovery doesn't occur. The key is to start early, ideally within the first few months after surgery, and to work closely with your urologist or a sexual medicine specialist who can titrate doses, troubleshoot side effects, and adjust the plan as you progress. What are the realistic numbers? This varies widely based on age, baseline erectile function before surgery, whether nerve sparing was possible, presence of other conditions like diabetes or vascular disease, and individual healing. But broadly speaking, in men under 60 with good baseline function who undergo bilateral nerve-sparing surgery, somewhere around 50 to 70% will regain erections sufficient for intercourse by 18 to 24 months, often with the help of medications. In older men, or men where only one nerve could be spared, or men with other risk factors, that number is lower, perhaps 30 to 50%. If no nerves were spared, spontaneous return of erectile function is unlikely without more invasive therapies. Now, let me be very clear, the absence of spontaneous erections does not mean the end of your sex life. We have effective treatments, and if conservative treatments don't achieve the rigidity or spontaneity you're looking for, there is a durable, highly effective solution: the penile implant. A penile prosthesis, also called a penile implant, is a surgically placed device that allows you to achieve an erection on demand. There are two main types: a semi-rigid rod that keeps the penis firm but bendable, and an inflatable prosthesis that more closely mimics a natural erection. The inflatable type has a pump placed in the scrotum, cylinders placed inside the penis, and a reservoir of fluid in the abdomen. When you want an erection, you squeeze the pump, which transfers fluid into the cylinders, creating rigidity. When you're done, you press a release valve, and the fluid returns to the reservoir. The penis becomes soft again. It's elegant, it's concealed, and for men who are good candidates, satisfaction rates are extraordinarily high, often above 90%. Recovery from implant surgery takes about 4 to 6 weeks before you can resume sexual activity, and there are risks like infection or mechanical failure. But modern devices are very reliable. I mention this not to push surgery, but to reassure you that no matter what happens with nerve recovery, you have options. Your sexual life is not over. It may look different, and it may require adaptation, but intimacy, pleasure, and connection are absolutely possible. Let's also talk about the fact that intimacy is broader than penetrative intercourse. During the recovery period, which can stretch over many months, communication with your partner becomes crucial. This is a time to explore other forms of physical closeness, to talk openly about fears and expectations, to support each other emotionally. Many couples find that this challenge, while difficult, ultimately strengthens their bond. It forces conversations that might never have happened otherwise. And for men without a partner, or men who are dating, I encourage honesty and self-compassion. You are not broken. You're recovering from cancer treatment. Anyone worth being with will understand that. And when you're ready, whether with medication, injection, device, or implant, you will be able to engage sexually again. Mental health matters here too. Anxiety and depression are common after any major surgery, especially one that impacts such personal aspects of life. If you're struggling, talk to your doctor. Therapy, support groups, and sometimes short-term medication can make a world of difference. There is no shame in seeking help. Now let's talk about the different surgical approaches to prostatectomy, because this is something patients often ask about, and there's a lot of marketing noise out there. There are three main techniques: open radical prostatectomy, laparoscopic radical prostatectomy, and robot-assisted laparoscopic radical prostatectomy. Open surgery involves a single incision, either in the lower abdomen or in the perineum, the area between the scrotum and anus. The surgeon operates directly with their hands. Laparoscopic surgery uses several small incisions and long instruments with a camera, allowing the surgeon to work inside the abdomen while viewing a monitor. Robot-assisted surgery is a type of laparoscopic surgery where the surgeon controls robotic arms from a console, providing magnified three-dimensional vision and highly precise movements. Here's what you need to know when performed by experienced surgeons. All three approaches have comparable oncologic outcomes. That means the cancer cure rates are equivalent. The cancer doesn't care which technique was used, it cares whether it was fully removed with clear margins. The differences lie in recovery profile, complication rates, and certain functional outcomes. Robot-assisted prostatectomy has become the most common approach in the United States, and for good reason. The enhanced visualization allows for meticulous dissection around the nerves, potentially improving nerve sparing and thus erectile function recovery. The smaller incisions generally mean less pain, less blood loss, shorter hospital stays, and quicker return to normal activity. Some studies suggest faster return of continence and erections with robotic surgery compared to open. Though individual results vary widely, there can be fewer wound complications and hernias. That said, robotic surgery is not automatically better for every patient. What matters most is the skill and experience of your surgeon. A highly experienced open surgeon may achieve better outcomes than a less experienced robotic surgeon. Volume matters. Surgeons who perform a high number of prostatectomies each year tend to have better results. Don't be afraid to ask your surgeon how many prostatectomies they do annually, what their complication rates are, and what their patients' continence and erectile function outcomes look like at 1 year. These are reasonable questions, and a good surgeon will answer them transparently. Some men prefer open surgery because it's tried and true, or because of anatomic considerations. Some prefer robotic because of the faster recovery. The choice should be a shared decision based on your cancer characteristics, your surgeon's expertise, and your personal values. No discussion of prostatectomy would be complete without talking about potential complications. Surgery is safe, but it's not risk-free. The most common early complications include bleeding, infection, and blood clots. Significant bleeding during or after surgery is rare with modern techniques, but if it occurs, it may require transfusion or return to the operating room. Infection can happen at the incision sites, or less commonly, deeper in the pelvis. We watch for fever, increasing pain, redness or drainage, blood clots, particularly deep vein thrombosis in the legs or pulmonary embolism in the lungs, are a concern after any pelvic surgery, which is why we emphasize early walking and sometimes use blood-thinning medications. Warning signs include sudden leg swelling, chest pain, or shortness of breath. Call your surgeon immediately if these occur. Anastomotic leak, where urine leaks from the reconnection site, is uncommon but can happen. It usually heals on its own with the catheter left in place a bit longer. Bladder neck contracture, or scarring that narrows the connection between bladder and urethra, occurs in a small percentage of men and can cause difficulty urinating. It's treatable with dilation or a minor procedure. Hernia at the small incision sites can occur, especially with laparoscopic or robotic surgery, though it's relatively uncommon. Rectal injury is exceedingly rare, but possible, given the proximity of the rectum to the prostate. If it happens, it's repaired during surgery. The key is to know what's normal and what's not. Some discomfort, fatigue, and minor changes in bowel or bladder habits are expected. Severe pain, high fever, inability to urinate after catheter removal, heavy bleeding, or signs of clot. These require prompt attention. You'll have follow-up visits scheduled in the first few weeks and months, and your surgeon will be monitoring for any of these issues. Most men sail through without major complications, but vigilance and communication are your safety net. Let me walk you through a realistic recovery timeline, week by week and month by month, so you know what to expect. In week 1, you're home with the catheter. You're taking it easy, short walks around the house or the block, but no heavy lifting, no straining. Pain is manageable with medication. You may feel tired, which is normal after anesthesia and surgery. Your job is to rest. Stay hydrated, eat a balanced diet with plenty of protein for healing and fiber to prevent constipation, and keep the catheter site clean. By week 2, you're getting more comfortable. The soreness is lessening. You might start to feel restless or frustrated with the catheter. That's a good sign that you're healing. Round day 7 to 14, you'll return to the clinic for catheter removal. Some surgeons do a cystogram first, a quick X-ray test where contrast dye is instilled into the bladder to confirm there's no leak at the anastomosis. If everything looks good, the catheter comes out. That first void on your own is a milestone, even if it comes with some leakage. Weeks 3 to 6 are about building activity gradually. You'll start pelvic floor therapy. You'll notice improvement in continence, even if it's slow. You can usually return to light work, desk jobs, for example, around 2 to 3 weeks post-op. Avoid lifting anything heavier than 10 to 15 pounds until at least 6 weeks. No strenuous exercise, no heavy yard work, no golf or tennis yet. Listen to your body. If something hurts or feels wrong, dial it back. By 6 weeks, most men are cleared to resume normal activities, including exercise. Start slow walking, swimming, cycling on flat terrain. Avoid high-impact activities or heavy weightlifting until you're confident in your core stability and continence. This is also when you can usually resume sexual activity, though keep in mind that erectile function may not be back yet. Intimacy can include non-penetrative options while you're working on rehabilitation. Months 3 to 6 mark significant milestones in continence. You'll likely see steady improvement, Some men are dry by now, others still use a pad or two. Keep up with pelvic floor exercises, stay patient. Months 6 to 12 are when erectile function recovery often becomes more apparent. If you're on a rehabilitation program, you may start to notice more frequent or stronger erections. If not, this is a good time to talk to your doctor about adjusting the plan. Continence continues to refine. By 12 months, you're looking at your new normal. Most men are dry or near dry, sexually active in some form, and back to all their usual activities. Size undetectable, and they are living cancer-free. That's the goal, that's the hope, and for the vast majority that's the reality. Let's talk about lifestyle factors that accelerate healing and long-term health. Nutrition matters. Your body needs protein to rebuild tissue. Think lean meats, fish, eggs, beans, Greek yogurt. Aim for adequate calories. This is not the time to diet aggressively. Fiber is crucial for bowel regularity. Straining during bowel movements increases abdominal pressure and can worsen urinary leakage or even cause hernias. Eat whole grains, fruits, vegetables, and consider a fiber supplement if needed. Hydration is key, but balance it. Don't overdo fluids right before bed if nighttime leakage is an issue. Limit bladder irritants during early recovery. Excessive caffeine, alcohol, carbonated drinks, artificial sweeteners, spicy foods, these can increase urgency and frequency. Sleep is when your body heals. Aim for 7 to 8 hours a night. If pain or catheter discomfort disrupts sleep, talk to your doctor about adjusting medications or positioning strategies. Stress management is not optional. Chronic stress impairs immune function and slows healing. Whether it's meditation, prayer, time in nature, hobbies, or therapy, find what centers you and make it a priority. Exercise is medicine. Once cleared, engage in regular physical activity. It improves circulation, supports pelvic floor function, boosts mood, and helps manage weight. Obesity is a risk factor for poor surgical outcomes and for cancer recurrence, so if you're carrying extra weight, this is a great time to work with a nutritionist or trainer. Cardiometabolic health. Blood pressure, cholesterol, blood sugar matters for erectile function and overall longevity. Many of the same risk factors that cause heart disease also cause erectile dysfunction. Manage them aggressively. Quit smoking if you smoke. Smoking impairs wound healing and worsens erectile dysfunction. It's one of the best things you can do for your recovery. Avoid heavy lifting, intense abdominal exercises, or activities that sharply increase intra-abdominal pressure for at least 6 weeks. When you do return to the gym, consider working with a pelvic floor physical therapist to learn safe lifting techniques and core engagement that protect your pelvic floor. Small, consistent choices add up to significant outcomes. Follow-up care after prostatectomy is lifelong, but it's straightforward. Your primary tool is the SAW blood test. After surgery, your SAW should become undetectable, usually defined as less than 0.1 nanograms per milliliter. That's because the prostate, which produces SAW, is gone. You'll get your first SAW test around 6 weeks post-op, then every 3 to 6 months for the first few years, then annually if everything remains stable. If your SAW starts to rise, what we call biochemical recurrence, it doesn't mean the cancer is back in a way you can see or feel. It means there are cancer cells somewhere producing SAW, either in the surgical bed or elsewhere. At that point, we investigate with imaging and discuss options, which may include radiation to the prostate bed, hormone therapy, or watchful waiting, depending on how fast the SAW is rising and other factors. The majority of men never experience recurrence, but even if SAW rises, we have effective salvage treatments. The important thing is to stay on top of surveillance, so we catch any issues early. You'll also have routine visits where we assess continence, sexual function, and overall quality of life. Don't hesitate to bring up concerns at any point. If you're struggling with leakage at 6 months, we can intervene sooner. If erections aren't improving by a year, we can escalate therapy. Proactive management is always better than suffering in silence. I want to circle back to the mental and emotional side of this, because it's easy to focus on the physical recovery and forget that your mind and spirit are healing too. A cancer diagnosis is traumatic. Surgery is a major life event. The weeks and months of recovery can feel isolating, frustrating, and uncertain. It's normal to feel anxious about the cancer coming back. It's normal to grieve the loss of easy, spontaneous erections or the convenience of never thinking about urination. It's normal to feel vulnerable, to question your masculinity, to worry about your partner's satisfaction or your own self-image. All of these feelings are valid. What's not okay is to bottle them up or assume you have to tough it out alone. Talk to your partner, be honest about what you're experiencing physically and emotionally. Most partners are far more concerned about your health and presence than about perfect sexual performance. Intimacy is about connection, trust, and affection, not just mechanics. If you don't have a partner, lean on friends, family, or support groups. Many cancer centers and urology practices offer support groups specifically for men after prostate surgery. Hearing other men's stories, realizing you're not alone, and learning how others have navigated the same challenges can be incredibly validating. If you're dealing with depression or anxiety that doesn't lift, talk to your doctor. There's no shame in medication or therapy. Taking care of your mental health is just as important as taking care of your bladder or your erectile function. You are not weak for struggling, you are strong for seeking help. Let me share a composite story details change to protect privacy that captures the arc of recovery. I think of a man I'll call Tom, who came to me at 58 with newly diagnosed prostate cancer. He was terrified. He'd heard stories about his uncle, who's been incontinent for years after surgery, and his brother-in-law who's never had an erection again. Tom was a runner, a husband, a grandfather, and he wanted to live to see his grandkids grow up. We talked through his options: surgery, radiation, active surveillance, and together we decided on robotic prostatectomy with nerve-sparing intent. His surgery went smoothly. He went home the next day with a catheter. He hated it, but he followed instructions, walked daily, ate well. Catheter came out at 10 days. He leaked a lot more than he'd expected. He was wearing 3 pads a day and felt defeated. I reassured him it was early. We started pelvic floor therapy at 3 weeks. By 6 weeks, he was down to 2 pads. By 3 months, 1 pad. By 6 months, he was dry all day and used a pad only for long runs just for security. At 9 months, no pads. He was elated. Erectile function took longer. We started him on Tadacalide and a vacuum device at 6 weeks. At 3 months, he had some tumescence but not enough for intercourse. We added injections. That worked well. By 12 months, he was starting to get spontaneous morning erections again, not perfect, but real. At 18 months, he could achieve erections with medication alone, firm enough for sex, and he told me his relationship with his wife had actually deepened through the process. They'd communicated more openly, experimented with different forms of intimacy, and felt closer than they had in years. His SAR remained undetectable. He was cancer-free. Was it easy? No. Did it require work, patience, and vulnerability? Absolutely, but he came through it, and he's living a full, joyful life. That's the story I want you to hold on to. I want to close with this. Prostate cancer is a formidable diagnosis, but in most cases, it's beatable. Radical prostatectomy is not a magic bullet with 0 side effects. It's major surgery with a recovery process that demands your participation, but it offers something precious: the chance to eliminate cancer. To live years or decades cancer-free, to watch your children grow, to travel, to love, to build, to matter. The road through recovery may have bumps, leakage, erectile challenges, emotional ups and downs, but you are not walking it alone. You have a medical team. You have therapists, nurses, and support staff. You have partners, friends, and communities. You have knowledge, tools, and treatments that didn't exist a generation ago. And you have agency. You can do the pelvic floor exercises. You can show up to physical therapy. You can take the medications, use the devices, ask the questions, and advocate for yourself. You can choose to see this not as an ending but as a new chapter, one where you fought for your life and won. I've watched thousands of men walk this path. Some breeze through. Some struggle, but the overwhelming majority come out the other side healthier, wiser, and grateful. They live, they thrive, and so will you. Before we wrap up, I want to ask you again: comment below with your biggest question about prostate surgery, continence, or sexual recovery. Subscribe to this channel for ongoing guidance and support. Share this video with a friend, a family member, anyone who's just been diagnosed and needs to hear the truth without the fear. Together we build a community where men don't suffer in silence, where information is clear and compassionate, and where hope is not just a feeling, it's a plan. Thank you for trusting me with your time and your concerns. I'm Dr. William Carter, and I'm here with you every step of the way.